We're devolving quickly here.
That's what we do.
What can I say? Welcome once again to the Free Associations podcast from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone as confused by the latest health study as I am by the process to enroll your children for summer camp. Starting in December and January of the year before.
You waited till December?
Yes. Okay, let's talk about this because your children are older, so you obviously have a little more experience. October.
So my parents for years and years and years have every Labor Day they go to the same hotel in Ogunquit, Maine, and when they leave, they book again for the next year. And I think that's the way you have to deal with summer camps.
Just on the way out, like the
on
last
the way
day.
out, just put your deposit down.
Just give your deposit.
Because otherwise you'll never get in.
Crazy.
Yeah.
Your daughter's too young.
Too young
for this sort of situation.
Right.
Yes. Well, something to look forward to, and we'll give you the tips.
Thank you.
Like when they say that registration opens at 9 a.m., as I experienced this morning, by 9:03, the whole summer is full with the exception of 2 weeks.
So most people write a computer script that actually...
Oh, my goodness.
Yeah, no, they don't.
I was going to say, should I get started?
They camp out the night
and we're just going to work on this for the next 8 years.
Yeah,
and then
exactly.
I've got some time, so I can perfect the algorithm.
No, but it is a maddening thing. I mean, remember the day, once upon a time, if you wanted to get like tickets to something that were really hard to get, you had to camp out. It still happens some places, but most of the time you just have to have buying tickets to a concert now or a professional sports event, I think has become like absurd in that they all get purchased immediately and then resold. So it's like people buy them as an investment effectively and just drive up the price. So you cannot go see any sporting event that people really are interested in without paying huge amounts of money.
Right. Do you think though that like summer camp, which is maybe as glorified childcare, like falls in that circumstance? Like I feel like, you have like Taylor Swift and then you have like day camp, and it's just amazing to me the intensity, because there also seems to be like a lot of day camps, and like a lot of them I think are pretty good, but apparently there's some hierarchy of quality and also I think it's also just the intensity of the community.
If you don't get into the right summer camp, you can write off your kid's future.
Yeah,
There's just
exactly.
no point. There's no
exactly.
point.
I think it's indicative of the larger issue that we have right now around accessibility of childcare.
Right.
It's a bigger problem.
I agree.
Anyway, goodness gracious. I'm Jessica Liebler from the Department of Environmental Health here at the Boston University School of Public Health. And I am joined again by my friend, Dr. Matt Fox from the Departments of Epidemiology and Global Health. Welcome, Matt.
Good to be here. Good to not be hosting.
Very good. And we also have joining us today Dr. Amruta Nori-Sarma from the Department of Environmental Health at the Boston University School of Public Health, a returning guest host, and we're so happy to have her with us. Welcome, Amruta.
Thank you so much for having me back.
Now on to the show. Today in our first segment, our Journal Club segment, we're going to take a look at a study focused on the effect of a workplace intervention on cardiometabolic risk. In the second part of the podcast, our deep dive segment, we'll talk about mental health as a human right. And in our famous, amazing, and amusing segment, we'll jump into some things that have made us laugh out loud or we otherwise just found fascinating in the last few weeks. So into segment one, we're getting into an article that looked at a specific workplace intervention and the relationship between this intervention for workers across different industries on cardiometabolic health. It was published in the American Journal of Public Health, and the study was titled Employee Cardiometabolic Risk Following a Cluster Randomized Workplace Intervention from the Work, Family, and Health Network, 2009 to 2013. By first author Lisa Berkman of the Harvard Center for Population and Development Studies in Cambridge. There were a number of headlines that came out on this study. First one being from the MSN Network, Harvard study finds having flexible working hours good for your heart. From Science Mag, increasing workplace flexibility associated with lower risk of cardiometabolic stress. New study shows increasing workplace flexibility might lower cardiovascular disease. This comes from WHD TV. Is that one of our local TV stations?
I believe it is. HDH?
WHDH? No.
HDH is local.
It's local. It's like the old Channel 7.
Yeah.
And one from usnews.com, people's heart health improves in more, quote unquote, flexible workplaces. So Matt, let's get started by asking you to describe this study and what they found.
Can do. Okay, so I think we are converging a little bit on a theme here in that the second segment that we did last time was about mental health. This is an intervention designed around mental health in its relation to physical health in the workplace. And then we're going to talk about mental health in the second segment. So I feel like things are kind of converging. So work is an important determinant of health and well-being, or much of our lives are spent at work, and therefore it determines, many of the things that we are exposed to, our mental health, our physical health. And it's also shown to be central in shaping inequalities in health. So the distribution of health differs depending on whether or not you're employed and then where you're employed. So this study comes in against the backdrop of concerns that people have about the challenges that people are having with work and the conflict that it creates between work-life balance in the United States, particularly as work demands are increasing. And this was a number that was talked about in the introduction, that they said about 70% of U.S. workers report some interference between work and non-work. I don't know specifically what that means, but I think we can all relate to the idea that work infringes upon life, creates challenges for us. Working long hours means we have to find ways to take care of kids and things like that. So there's a lot of challenges. So these authors felt that given that, they wanted to think about workplace redesigns that could potentially reduce the stress of workplaces and then potentially have an impact on measures of physical health. Now, one of the key organizational conditions that shapes workplace risk is the ability to go to work without creating undue hardship and strain on family responsibilities. And this gets to the work-family conflict. So, and it also worth noting, there are these biologic mechanisms that have been linked to work stress and cardiovascular disease. The ones that you would probably think of, like inflammation and cardiovascular reactivity, atherosclerosis, things like that. So things that are all sort of artifacts of coming to work. So what they wanted to do was design a workplace intervention that would potentially address some of these issues. They designed this intervention they tested in a cluster randomized trial. It was designed to increase family supportive supervisor behavior and employee control over work time. And so what they did was they designed this intervention in which they gave supervisors training focused on increasing supportive work-family behaviors, and they did these work redesign activities aimed to modify practices and interactions in workplaces between employees and their supervisors, specifically focused on increasing employees' control over work time and supervisor awareness and support of work-family balance. So, I think there's some questions there as to whether this could be done in all industries, in all, workplaces, but in the ones that they were working with, they clearly could do this. Then they tested this with a randomized trial, cluster randomized trial, at two companies with multiple different work sites. The two workplaces were long-term care facilities and multiple work units in the IT sector, both in the United States. And so then they randomly assigned these work sites within the companies so that you have a clustered intervention. So it's not an individually randomized. Either your workplace is assigned to the intervention or not, because obviously this is a group level intervention. They have these trainings where teams identified new work practices to increase employee control over work time and to try and reduce low-value tasks. Again, not clear whether this could be done everywhere, but certainly where it could be has the potential to increase people's happiness. So they run this intervention, and then they wanted to test it against the primary outcome of a change in a validated cardiometabolic risk score, or the CRS, which is calculated using various different things that you would think of that, they check when you go to the doctor, like your blood pressure, your BMI, your cholesterol levels, things like that. They had follow-up assessments that included in-person interviews, and they did biomarker collection. They collected these measures at baseline. They do the intervention, then they collected them again at 12 months, and they looked to see what the change was. They also did some self-reported measures with a computer-assisted interview, but largely were focused here on the specimens. This was done from September of 2009 to July of 2011. They did some fancy regression models to deal with some of the between-group differences. When it's a cluster randomized trial, you don't necessarily get the same kind of balance that you would get in an individually randomized trial. And worth noting, one thing that they did was they pre-specified, and I think this is important, that they would stratify the results by baseline cardiovascular scores. In other words, they would stratify by whether or not people were at high risk for cardiovascular events or low risk for cardiovascular events. And then they tested the effect of the intervention on their 10-year cardiovascular risk score, that score that I was mentioned in the beginning. They did have a fair bit of attrition. So I couldn't get the exact number. It seemed to be in the neighborhood of 60%, though it didn't differ between groups. And so then they get their results and they found no real difference. You could say there was a slight difference in the effect of the intervention on CRS scores overall. However, what was noteworthy was they did find a difference in the group that was at high risk for cardiovascular disease. And, that sort of makes sense in a way, right? If you are at low risk for cardiovascular disease, you might not expect much of a change, but if you're at higher risk, then interventions might potentially work. Hard to know what to make of the specific numbers here because these are changes in scores. So I won't give you the details, but overall the results suggest that this is, an intervention, at least for those who are at high risk of cardiovascular events, might have some benefit. We can talk about whether or not the costs that an intervention like this might have are worth the benefits and whether we think the benefits are big enough. But overall, a positive finding from what I thought was a reasonably well-designed and well-implemented study.
Thanks, Matt. That's really interesting. Thank you for giving us that overview. Amruta, I'll turn to you. What were your key takeaways or the key things that jumped out to you from this paper?
Yeah, so I thought this was really interesting. And one of the things that I think is worth highlighting, which, comes across even in the title, is that this is all work that was done looking at workplace flexibility pre-COVID. And I think that it has meaningful implications for the way that we think about the changes to the structure of the workplace during and post-COVID and the potential long-term impacts that this might have on both physical health outcomes as well as mental health outcomes, thinking through the theme that we have for today's episode around mental health. I know that there was a lot of discussion, during COVID and during, work from home period, and then in the hybrid work from home, work from office model. And a lot of that was focused around how we provide care. We talked about childcare in the beginning, but I think it's not just childcare. It's also about the way that we provide elder care. And so I think that the reason why I thought this was a really interesting study is because it brings together and sits at the intersection of a lot of these different issues that I've been thinking about. And I think a lot of my colleagues have been thinking about, what does hybrid work or work from home look like in post-COVID era? And then also, how do we take into consideration the additional stressors for people who are working in office of childcare, of elder care? And, where is that balance that we need to strike between, flexibility in the workplace, but also making sure that people have access to the resources that they could potentially get from a work in office model. And, this is very clearly something that people were thinking about and looking at 10 years before, where we are currently sitting post-COVID.
It's interesting. I hadn't really thought about the fact that this was pre-COVID, and of course, so much has changed in workplaces with COVID and then post-COVID. Not that we're post-COVID, but you know what I mean in terms of the emergency phase. I hadn't really thought about the implications. I mean, so I'm curious. Do you think this actually tells us more because work has actually changed to become more flexible, or that the results actually are less generalizable because so much else has just changed during COVID that maybe, every workplace is now just sort of very different? I'm wondering what you think.
Yeah, I think it might be the case that we need to reinvestigate some of these interventions that we're implementing now. And we might also, one of the things that they did in this study is they looked at baseline cardiovascular risk scores, and one of the major measures that they're using is what is your 10-year likelihood of a cardiovascular event. And now we are 10 years post the original data collection. So I think one of the things that would be really interesting would be to follow up with those folks who participated in the study to see how much of the cardiovascular risk score actually translated into an outcome. And also if we could look at that measure potentially mediated by the changes in workplace structure, especially that were happening in long-term care facilities during the COVID period, right? This is one of the epicenters of a lot of the changes in the initial workplace structure because of the nature of the pandemic and how it was really concentrated in these long-term care facilities. So I think there's a really interesting potential we have data from 10 years ago, pre-COVID, and now we could start to look at some of the same folks working in these places of interest.
I had actually assumed that in part that was what this paper was setting the stage for, because it is 10 years right now. They didn't actually present health outcomes in their study participants. They just presented the risk score and kind of dangled in front of us the 10-year risk. And so my sense is that maybe that's why they were looking at this now, because they were intending to go back and look at these different workplaces. And you're right. What was interesting about the two workplaces that they chose is that they were ones that, looking at them now, 10 years later, were particularly affected by kind of COVID work reshuffling, where there was, we were talking about long-term care, and for sure, and then the IT sector also, was deeply affected in terms of the remote work situation, in terms of people being able to work in a long-term remote capacity. So the office setting in that industry has changed fundamentally.
So this is one of those experiences where you don't miss it, but you don't pay attention to one detail, and then it completely shifts everything. So first of all, I think it's worth clarifying two things that I probably didn't either say or stress. One is that this was a large study. It was 5,000. They randomized 5,000 people in each industry, so 10,000 people. So you got a big population. But these were, the other thing is, so these were, their primary outcome was these 10-year risk scores. Just worth highlighting for the audience. That does not mean that was their risk over 10 years. They were not followed for 10 years.
Yeah.
That's a score that is predicted
predictive score.
You are.
That was derived from Framingham as a predictive score, and then they applied it on this data from 2009 to 2013.
So why are we just now getting results from a study that was from 2013? Amazing that I missed it, by the way, since it's in the title, right? I mean, I saw it, but I didn't really pay attention to it.
In your defense, the title's super long. I don't know how you feel about that.
And the dates are all the way at the end of it. I mean, my assumption is that this is a currently active cohort and where they may potentially be continuing to collect follow-on data from the same cohort. And I would assume that there's something interesting to be done with the follow-up information that has been obtained from this cohort over the course of the 10 years between the original data collection and COVID period. And it seems to make sense given that they were doing predicted risk scores as part of their main measure, of effect, looking at the original participation. I would assume that there would be something to look at, including how many of the participants actually experienced adverse cardiovascular outcomes in the intermediate 10 years, potentially looking at the ways in which during COVID workplace flexibility mimicked the original intervention and how that might have had implications for health for the participants 10 years after the original data collection. And one of the things that, is a key component of this is that long-term care facilities experience some of the most dramatic increases in adverse health outcomes among the patients as a result of the COVID pandemic, and was also a place where workplace flexibility really originated in meaning during the pandemic. And so I think they have a really rich potential set of participants who were in the original study who could potentially be looked at now, given the context that the pandemic kind of provided us around workplace flexibility.
Yeah, a lot of challenges there, though, of course, because you're right that the work conditions in some ways did mimic what was done in this study during COVID time, but COVID was also itself a really stressful time that you might think that might have changed, risk for the worse as well. So it would be hard to tease that out, but really an interesting opportunity. Yeah.
Absolutely.
I was wondering if either of I struggled myself to actually find what the intervention was. Where for some reason, I wasn't able to find the active links in the paper to the supplements, because I was like, what? They talked about it, but I wanted to know, what actually were they doing? And so I ended up just Googling this study. And then on the study website, they have PowerPoints that some at least, and I think some of it's proprietary. Some of it's proprietary in this, in an intervention space that I think looks like companies can purchase this intervention, and then others of it were publicly available. And it was really interesting because for the IT sector, it was very focused on kind of breaking down the constructs of the 9-to-5 workday and saying, what if at 2:00 you could go watch a movie, you could go to the movies and then do the work that you had to do at 10 p.m. And all that mattered was, could you get your work done? It didn't matter when you did it. And so much of that actually came true during the pandemic, where we were all at home and you had, for some of us, you had your children running around, or you were just, there was lots of stuff going on, and like the whole workday kind of disappeared almost in the way that they were envisioning in this intervention. And you were working all night, you were working all day, you were up in the night. It was like the like day became night and night became day, and it became very confusing from a workplace. And there was all these other external pressures also. So it wasn't just work, but it also led me to think that some of the fundamentals of the intervention had to be changed. And so I wondered if that's why, because, the things that they're proposing now, many of these things already exist, at least in the IT sector, which has become very remote heavy or hybrid heavy, a very limited kind of fully in-person workforce, which is different from the long-term care sector.
Yeah.
The interventions they were proposing at this time in the 2009 period for the long-term care sector were focused on the workers identifying extraneous or useless things that they were being asked to do and trying to empower them to alert their supervisors, like where they're wasting time, basically, to say, I'm doing this activity, but it doesn't seem to be contributing anything useful, or I'm doing it and then this other person's also doing it, or we're doing it at the wrong time of the day. So to kind of try to use that knowledge from the workers to inform the effectiveness, the kind of day-to-day efficiency of the work environment, because they don't, you can't, some of those tasks, they're not flexible in that way. Like things have to be done at certain times in certain orders with certain patients. So that was an area where it seemed that the intervention still could work now in COVID, but the one with IT was very different. And so it was not easy to actually get my hands on what exactly they were doing. But I imagine that maybe that was a motivation too, is that they have to revamp at least one of the interventions in this new context. And they were trying to do like a pre-post.
Definitely possible.
But it was very interesting to see the content of what they were actually sharing with the workers. And then also to see, they talk about it in the article, but how many of the individual workers did not attend the sessions. And so thinking through what could be the effect on their ultimate estimates if you had work groups where 60% of the people in that work group, for example, were not at the session where they were presenting this information.
Yeah, although, it is a group level intervention, and it is possible that you have an intervention that even if, some people or many people don't attend, the benefits still accrue to those. So it's a possibility. I was wondering, it makes sense to me in some ways that this comes out of a school of public health, but there's part of me that thinks why isn't this kind of thing coming out of a school of business school or, I don't know, somewhere else? Obviously, it does make sense to think about workplace interventions and mental and physical health. But if these interventions are, say, good at improving people's happiness and they don't necessarily improve their health, wouldn't we also think that was a good idea and something that might help companies retain employees, keep them happier, whatever it is, be more productive? I don't know. So there's a part of me that thinks I don't know if these are beneficial interventions, even if they didn't improve health, we would still care.
Right.
So I don't know. It seems like there's so many other outcomes that you might be curious about the effects of this intervention on. I don't know. I'm just...
One of the reasons, I agree with you. And I think one of the reasons, again, we were going back to why was this published now in AJPH. And I think one of the reasons is that among the participants who had these higher risk scores, the effect was substantial.
Yeah.
And so that was attention grabbing. That was attention grabbing.
I have a hard time interpreting these numbers because it's a risk score.
I
so what does
only
it drop in a risk score mean?
They interpret it towards the end where they say it's the equivalent of 5 to 10 years of age in the cardiometabolic risk space, whatever exactly that means, but kind of saying maybe if you're a 40-year-old person, you're not aging at this, you're kind of aging to a different level or aging at a different pace.
You'd have the heart of a 35-year-old.
You have the heart of a 35-year-old, right. And that was pretty substantial, I think, in the cardiovascular epispace. Those findings, even though there are assorted limitations. So I think that could also have been part of the reason why it was published here and published now because of the dramatic effect. And the implication that could this be stemming from the natural experiment of hybrid work or remote work? Could we be seeing some of these benefits now Although,
Right.
as you said earlier, they'd definitely be offset by some of the other pressures imposed by the pandemic.
Right.
I agree. And I think that cardiovascular disease risk being as high as it is, those are meaningful impacts that we're seeing. From the other areas that I'm more familiar with, like the air pollution literature, these types of changes in cardiovascular disease risk would be really meaningful. So the fact that they're able to see that with an intervention like this, I think is really an important finding, particularly among people who have that elevated risk at baseline.
So the risk score itself is largely made up of systolic blood pressure, BMI, hemoglobin, HbA1c, tobacco consumption, HDL, high density lipoprotein, and total cholesterol. So I'm just trying to think through what are the most likely impacts? Like, is this presumably bringing down people's blood pressure mostly? I would think that I don't know this. I don't know the field well enough, but I would think the biggest thing you could do to improve your heart health would be to quit smoking. And this doesn't seem to be focused in any way on getting people to quit smoking. So I can't imagine it's that, but maybe it is. I would be curious to know the individual components and what we think that this is actually impacting. And then the second thing would be, I'm curious to your thoughts on how transportable this intervention is. I mean, when you do drug studies, you get an effect and it's not the same in every population, but it's, it's reasonably transportable across populations. But interventions like this are going to be very specific to the both the sector that you're in, but also the company that you're in. And given that we now know that the intervention benefit is in those who are at highest risk, it's also going to depend on the proportion of your population that is at high risk to begin with. So I'm just curious your thoughts on that.
My concern in seeing the content of the intervention, that it obviously required a substantial investment and motivation from the employer, right? To kind of say, we're breaking down the workday totally. And unlike before, where we had, one of the things was that meetings are now optional. Right? If you don't feel like there's a benefit, you're into this, right? But obviously the employer has to buy into the whole construct of breaking down the 9-to-5 work week. And many employers, I think, would not do that, even if they've leaned into some of the flexibility of remote or hybrid work. I think just still meetings or, the meeting flexibility or a lot of these things that you don't have to work along a traditional line.
Yeah.
So I think would be difficult. It would make it difficult to transport across industries. At least the IT version, the long-term care version that was more focused on the workers alerting their supervisors to efficiency problems, probably could be carried more broadly into different industries.
Yeah, and I think that this maybe gets into a whole other area, but focusing in on that long-term care component, I think that in addition to requiring the buy-in from the employers, it also requires buy-in from supervisors to say, like, we're going to take these trainings, we're going to take them seriously, we're going to implement those best practices that are provided for us. And I think that that's also an investment. And, they talked a little bit about the number of hours that are required for these trainings, and it's not trivial.
No, it's a lot of time. They're extensive.
Yeah, and I think in other literature, there's been demonstrations of the need for repeated trainings in order to retain the information that's being provided in occupational settings. But, going back to your earlier question about business school versus, coming out of a school of public health, I do think that this is, occupational risk factors is a really big component of public health literature, and I think it's really important to include. So, I mean, I think it is. I think it is where it belongs.
No. Sorry. I said that poorly. I guess my question was, if you think about the investment that this is going to take, what if I'm an employer, do I necessarily care that my employees' cardiovascular risk score is going down? Maybe I do. I mean, I would hope I do, but it's probably not my main motivator. Whereas if I found that it improved my employee retention, it improved productivity, then I might be more interested in investing in it. So I'm just sort of trying to balance those two things of how do you get people to want to implement something that might actually have benefits for health, by also relating it to things that they care about.
And it also wasn't clear to me that the effects that they were seeing were due to stress reduction rather than people using their time differently. Yeah. So, maybe you could free up time in your day to go to the gym, and then that affects your BMI, or you're able to cook, and that affects your diet and your cholesterol. So it's not always, it was not entirely, I mean, they didn't talk about which pathway necessarily was changing by changing the work schedule that was then affecting these results. And that would be a follow-up that I'd be interested to see. Kind of, was it that people changed the orientation of their activities in their day, or that it was just stress, like it was reduction in stress that then led to these other things? I think we should pivot because we've had a great conversation on this article. For our segment 2, we're talking about mental health in a different way. And this was an editorial in PLOS Medicine by Louise Gaynor-Brooke with the Public Library of Science in San Francisco. And the title here is Towards Mental Health as a Human Right, the Key Role of Lived Experience. And the author of this piece, this is a short commentary piece, is talking about the intersection of mental health with many chronic and infectious disease endpoints that are very central, that are viewed as very central to human rights, and making the case that mental health should be considered alongside these other very central themes. And to note also, this piece seems to be launching a new journal in the PLOS juggernaut of journals, this PLOS Mental Health.
We just need to stop and comment on that. The proliferation of journals. Like, there is now a journal for everything, even like under the auspices of, say, PLOS Medicine has their brand of journals, and then Lancet has their, there's like a journal for everything. So I'm waiting for the International Journal of Matt Fox so that I can just publish everything directly.
Everything you've ever thought in one peer-reviewed. But I think one of the interesting things here was just the linkage to human rights, which maybe is a less common theme focused in the mental health space. So Amruta, what were your thoughts on this? You want to jump in?
Yeah, sure. So I thought that this was a really interesting compilation of a lot of different mental health components that I've been thinking about, and I know that others have been thinking about as well. I really appreciated the perspective that we don't think of mental health in isolation. We kind of consider it as one of the contextual factors that, in combination with adverse physical health, can lead to overall reductions in well-being. And, one of the things that I think is really important is mental health has not traditionally been incorporated into some of the different considerations that we've had around environmental exposure and health impacts, around structural determinants of health, social determinants of health. And so I think that the thing that I really appreciated is focusing on mental health as a human right, I think brings mental health into the forefront in a way that it hasn't been traditionally considered, and I think alerts everyone to the need for consideration of mental health outcomes alongside physical health outcomes as part of a more holistic picture of the public health and the public good.
Yeah, I would agree with that. I am curious what you all think about the idea of naming something to be a human right. Because I mean, certainly, like many things can be declared a human right. You have the right to health in general, mental health specifically. You have the right to housing and security and things like that. But those are ideas, right? Unless that doesn't mean we can necessarily guarantee those things for everyone. So I'm just curious what you think the value is in declaring something a human right.
I agree with you that I think, in declaring something a human right, it certainly doesn't mean that we have any way of enforcing that everyone has access to, whether it's a human right to clean air, clean water, or good schools, or whatever it is. There's no way of mandating that in the context, like in a right to free speech, kind of in like a rights-based structure from a legal or policy framework. I think it just elevates the universality of the challenge of the idea.
And it makes it aspirational, right? Yep. I think that elevating it to the status of a human right, even if it's just a theoretical concept, makes it an aspirational goal towards which we can be working as part of the effort in practice of public health.
And it sets up the need for universal metrics, which in the mental health space is challenging in terms of how do you measure mental health? How could you do that in a way that's comparable and rigorous and broadly, broadly reliant across different populations?
Yeah, I guess my thought on that though is it something that's achievable? Because you could say a basic income is a human right, and that would have implications that are pretty clear. We'd have to figure out what we consider to be a basic income, and we would figure out how we're going to guarantee that everybody gets that access to that. Mental health or health in general are not the same. We cannot guarantee somebody's physical or mental well-being. We could mandate, people have access to health care. They could mandate they have access to services. So I'm saying, like, even even moving away from the theoretical to moving away from the practical to the theoretical, it isn't even totally clear to me what exactly that human right means in the context of something that we cannot, as a species, guarantee.
Well, I think that there's, maybe there's two different things that I would say. The first is that in some of the other items that you are mentioning, the metric comes on. So the metric is not on the individual side, I think. The metric of, free speech or some of these other things that we think of as basic human rights, there's like a kind of an external measure of it. Whereas I think one of the difficulties with something like health or mental health specifically is that it is such an individual level measure, because person to person, there may be a very different conceptualization of what well-being or good mental health really means. But I think that maybe extrapolating away from the particular, like, how do we concretely measure it, one of the things that I think we benefit from in explicitly calling out mental health in this context is that there's been so much stigma around the idea of mental health and seeking out access to resources or care. And so I think in providing this framework of, no, everyone is entitled to good mental health, what we're doing maybe is allowing people to say, I don't currently have that, and I need to go and get the resources that will enable me to be healthier mentally, to have better holistic well-being. And I think that in and of itself is an important goal, even if we don't, at the end of the day, know how to accurately characterize or quantify what good mental health is. I don't know that we necessarily need that. I think what we need is for people to understand in their own circumstance, this is how I'm currently feeling or how my mental health is currently. And also, I know, because there is now this idea just broadly in society that everyone deserves to have good mental health, that I can go and seek out the access to the resources that I need without feeling like there's some sort of stigma attached to that.
I agree with that. And I also would just add that I think it's a systemic issue as well, kind of. And so elevating something to a human right would then imply that healthcare providers or health insurance organizations would need to provide services or provide screening or just an increased awareness that if this is something on par with diabetes and cardiovascular disease and HIV in terms of big picture diseases that we think about globally, that providers and health systems need to be aware of mental health more than they are right now.
Yeah. So let me then say, couldn't we achieve that same goal by simply saying we're going to focus on that particular issue, or we're going to say, so in the world of HIV, going back many years, we were, there was no access to HIV treatment in most of the world. And then we made this commitment and, they started setting these targets. So if we're going to get X million on treatment by X period of time, and, those goals, you sort of looked at them and you said, like, there's no way you can achieve this. But if you don't set a goal and you don't actually monitor progress, then you're not going to get anywhere. So fine. So you have these targets that may not be perfectly achievable. So wouldn't doing that same thing for, say, mental health and saying, we're going to have some target that everyone is going to meet this, every country is going to get to this level of I don't know how we do it. Have the same benefit of focusing the attention and moving people in a direction, as opposed to saying something is a human right, which I'm not at all. I'm not disagreeing with this. I'm just trying to say, like, I'm trying to understand what the benefit is of declaring something a human right, as opposed to just saying this is going to be our health focus and we are going to target, we're going to create targets and we are going to hold people accountable to getting towards these targets.
Right. I mean, my sense of why, the author could have chosen a number of justifications for elevating mental health to the status of it's going to be its own PLOS journal, right? I think they could have chosen, this author could have chosen multiple rationales for making that case. And I think the human right issue touches on the global construct. And so kind of leads back, I think, to the comment that Amruta made, that there is stigma. And there's certain inequality and inequity in terms of how mental health is assessed and treated globally. So the idea of this is a global concern, it's a human right, that it kind of elevates to that level. I think it was more of a theoretical argument than, maybe we can't. And from a mental health perspective, there's no clear metric that we could say, we're going to bring everyone above a 10 in this score and we're going to commit to that, because there's no universal metric that exists. And so maybe that's kind of a call for that process.
And I just want to say, I know we've been focusing in this segment really heavily on the first part, which is mental health as a human right. But I just want to take a moment to pivot to the second part, which is the role that lived experience plays. And I think this is another important component of the journal, of the overall framework, which is that there's been a lot of discussion in the last couple of years, especially around diversity of opinions within publications, within our fields, within the discipline of public health. And I think this is also a means of elevating mental health to the forefront as, people with lived experience around mental health can provide perspectives on all of the different components that are listed from the Universal Declaration of Human Rights. So maybe the ways in which we provide access to the standard of living, for example, they talk about food, clothing, housing, medical care, these issues that you've mentioned, bringing in people with lived experience around mental health and around some of the different, adverse mental health outcomes, bringing those perspectives into these discussions for these other components of universal human rights, I think is also a really key part of what the author is advocating for. And I think that probably translates into, having scientists who participate in research discussions and in these really important fora who also have that lived experience that they can bring with them to the table. So I just wanted to mention that as a key component of this.
Yeah, and if I could just connect that back just for a second to what we were talking about before, which is the justification that I have heard for declaring something a human right is declaring something a human right doesn't make it immediately available and guaranteed to everyone. But what it does is it provides a legal framework for, say, like when things come up and laws are being made and they come to the courts, that the courts can now use that as a metric by which they are evaluating the progress. Not necessarily that you have done it, but they can say, look, that you have to attend to this. And so then coming back to your point. So then how do you then go about doing that? You bring in the perspectives of people who have experienced this and understand it. You bring in those who have expertise in the treatment side of things, and you bring in what's feasible and acceptable and all of those things to develop approaches, systems, programs, therapies, whatever it is, medications that help move towards that. And you've got a legal framework to move you in that direction. So, yeah.
Interesting stuff. I mean, I would just conclude with the one comment pulling on Amruta's section, a comment a minute ago. There was the quote towards the end, the nothing about us without us, which is the classic call for community-based participatory research, which is obviously very different than the style of research that's typically published in the PLOS journals, typically published in our biomedical journals more generally. And so that was an interesting tidbit, kind of wondering, was this journal in fact pushing towards more community-based engagement upstream in the research process focused on this topic. So anyway, cool discussion. Thank you both. Let's pivot to amazing and amusing. And Matt, what do you have? You want to go first?
So I'm going to go right back to where we started.
Okay.
As I said, which summer camp you get into determines your entire future. That, of course, is a joke. But this article that I came across that I found fascinating is back in May. It was came out on ProPublica's webpage reporting on something that they had been looking into, which is this idea. So when kids are in the United States who have access to lots of resources, are preparing for applying to college, they want to build up their CV, their resume, to make it look like they are the most outstanding, amazing, kid out there, and this, XYZ school should choose them. And so kids do things like, leadership activities, all good stuff, sports, good stuff. But then they also do things like get coaching and how to, present their, to engage in things that will help them, or coaching in how to write their essays, or coaching in how to take the standardized tests and all those things that if you have more money, you can then do things. relating it all back to our field, apparently there are now, and I didn't know this, there are now services who you can pay people to get your kids your high school student, a published paper that they can now put onto their CV. Wow. These things are like, thousands of dollars, as you would expect, because of course the fees that we pay to publish our articles open access, they're in the thousands of dollars. So these are services that then work with journals to get, these kids published. But the problem, of course, is that very little of it is actual good, useful, important research. And it ends up just sort of flooding. I mean, as we know, even those of us with degrees in this can often produce not particularly important or well-done research. Now you're going down to the level of high school, and they were saying like obviously there are some high school students who do brilliant things and should be published, and most of them shouldn't. And if the metric is I have money to pay for it, we have a really broken system. So I thought it was fascinating to learn that is true. I'm not in any way trying to suggest that this is like a really common practice, but just knowing that it's out there, that there are, whenever there is a system to be gamed, those with resources are going to try and get benefits for their kids. And it's just, I don't know, it's worrying.
It's crazy. I mean, and the schools kind of lean into that also, like our university and others, they have these programs for high school students to be doing, and they promote it along that, like kind of get engaged with high impact research and famous professors. And then often, the professors don't know exactly what to do with them because they're like 15 and 16, and it's hard to know exactly how to engage these students. But they pay $10,000, $15,000 for these summer experiences.
They pay.
The students pay, or the families pay for these experiences in academia. Shocking. And it's not always clear like what they can contribute. They need a lot of mentorship when they're in high school to be able, if like you're looking at a lab, for example, like you need a lot of training and mentorship to be able to really jump in and do high impact stuff. Yeah. But I see some of these programs and I feel like there's a discrepancy between what they promise the kids and then what the kids can actually do.
For sure.
Yeah.
And I experienced that. I mean, my first experience working in a lab was when I was 14, the summer between my freshman and sophomore year of high school. And I think it actually had a really huge impact on my career trajectory, being able to go work in a lab, understand what that experience would be like. So there is something valuable to be gained
in a positive
for the students.
Way, in a negative way. Yeah.
Right. But I think, the perspective entirely depends. For me, the motivation behind that wasn't that I was trying to get into college. It was that I was interested in gaining this new experience.
And that is good.
And I think we need to start differentiating between, I'm doing this on paper so that I can get into a good college because that's what I think I need for my future career trajectory versus I'm actually substantively interested in this topic and I want to contribute. And, I've seen both of these like different pathways of students coming through. And I think it makes a really big difference for their experience, for the experience on the other side. Yeah, I agree with you. I think it's really troublesome if it's just a pay to play situation.
Exactly. Right. So, and just to emphasize, I actually think those situations that you just described and you described as well, those are sort of two different things, whether you're like paying for an experience versus you're just getting an experience. The experience is fantastic. Like if you're in a real, lab experience, but these are things like, working with Chick-fil-A to write effectively a marketing piece for them. That's not what we're looking for.
Not,
Getting experience, I'm all in favor of.
Crazy.
Yep.
Amruta, what about you?
Yeah, so over the course of the last year, I feel like this has been the year of Taylor Swift, the decade maybe of Taylor Swift. And I've had so many conversations in places where the topic of conversation wouldn't naturally go to Taylor Swift, but somehow it ends up there, including the fact that we were driving down to my college reunion back in May for my 15th reunion, and we ended up getting stuck in Taylor Swift concert traffic south of the GW Bridge. So it has had a really like day-to-day level impact on me for at least the last 6 months, if not longer. And so it seems really appropriate that Taylor Swift has been named Time Magazine's Person of the Year. And so, the conversations around that, I think, in addition to the way that this has been a topic of conversation across the course of this year, I think just the marketing around all of the different concerts that she's been doing. And, there's some people who credit her with keeping up our economy this year. So I think there's just a large range of discussion around Taylor Swift. And so I thought that was really interesting. I think it came out today.
That's super interesting.
Do you think that Taylor Swift is the greatest pop star of all time? I don't know how you define greatest, but like when I think of like growing up, Michael Jackson went into my was the greatest pop star, but I kind of feel like I put those two together, and just if I think about like the we live in a very different world, so your ability to mass market and communicate and then whatever, but it just seems to me like we talked about Michael Jackson a lot when I was a kid, but like Taylor Swift is everywhere. It's as you say, like it's in every conversation, it feels like, and I cannot turn on a football game now without having to.
Well, now she's crossing over.
Personally annoys me, but
resuscitating other
careers.
Wait a minute.
No.
NFL
resuscitating.
Did not need to be resuscitated.
Talk to any Taylor Swift fan. I guarantee you they will disagree with
At least it's a different demographic, right? You weren't having teen girls tuning into a lot of the games before, but now they are, just to try to get a glimpse of Taylor in the box. But no, I mean, I have a 13-year-old daughter, and she's obsessed with Taylor Swift. And what's interesting about Taylor Swift, to me at least, is I think one of her appeals to my daughter is that she has this kind of persona of survival. Like she's kind of been through hard times, and like, you know, Kanye mocked her at the Grammys, and she came back even stronger, and she has like, and her music kind of reflects this like fairly cohesive narrative of survival in difficult circumstances, even though I don't, she's got billions of dollars. Obviously she's not like really living in difficult circumstances, but like there's something about her that teens relate to. Like I see it. That's right. And it's not her music. Like it's not just the music. It's like,
although the music is
a part of it, but I think it's like also just her whole persona, which is really interesting.
They're what?
Oh, what my savvier younger cousins say is that they're bops.
They're bops.
Yeah, they're good. They're good songs.
They slap.
You can bop your head. You can bop your head around to the music. Yeah, for sure.
On that note, we can bop over to my this is a random amazing and amusing, but I chose it because Amruta was here today, and it's an unusual theme. So this was an article that I just pulled about a group of researchers in Nova Scotia who said, who are focused on fish survival. And in river water, because river water is apparently increasing in temperature dramatically, especially in smaller rivers, and this is causing, species die-offs and declines, and the water's too hot for a lot of these fish species to migrate and survive. And so these researchers said, what about creating an air conditioning system?
A fish conditioning system.
A fish air conditioning system for the fish.
Wait, but is it air?
It's not air. It's not air. It's actually cold water.
Water conditioning.
Water conditioning. They were calling it air conditioning, but water conditioning. So what they did is they dug into the groundwater aquifer where the water is cold, and they pumped the water from the aquifer into the river, into kind of, defined areas. And then they said, like, what's going to happen to the fish? And the fish flocked to these cooler areas of water, to the extent that they weren't like migrating so much as they were just hanging out. Like, they were on these migratory paths. And first it was the young fish. And as the temperature, the external temperature and the external, like the ambient river water temperature increased, even the older fish who maybe were like seen it all, done it all, even like they came over to the AC and were just like basking in the AC. And so in reading this, I was like, what's the public health perspective here? Because, you think about climate change and adaptation and mitigation, and like from a hierarchy of controls perspective. And it seems like providing air conditioning to fish is the very bottom of a hierarchy control. Shows like everything else has failed to get to that circumstance. Maybe the last thing would be they'd put like an ice pack on an individual fish. Like they'd like strap it with like a little ice suit. But I was interested because this apparently seems to be a whole line of climate mitigation type research of altering, cooling the environment for animals. Yeah. And I was wondering what your take is on that. Being at the lower end of the, where your research is kind of more focused, a little maybe higher on the hierarchy of controls of kind of systemic issues.
Yeah, but I think it's an interesting, so there are a couple of things that I would say that are really interesting about this. So the first one is that this is one of the things that I would characterize as like a Band-Aid solution, right?
From public health very much, it seems that way.
Exactly. Sure. So like instead of trying to mitigate the circumstances under which these surface water bodies are becoming too hot for survival, we're pumping up groundwater from aquifers in order to cool off surface water, which has a little bit of a problematic component in and of itself because we don't really know what's in the aquifer, right? Or we don't know what's in the what the composition is of the surface water. And those two things can be very, very different.
No, but if we surveyed the fish, I think they would say they liked it.
They probably would say they liked it.
We did community-based participatory research with the fish.
Fish community participatory
really
research,
true.
yeah. But I just think it's really interesting because this is a classic mitigation versus adaptation discussion that happens, right? Like, do we assume that the water is going to be hotter and provide fish with the capabilities to survive in the hotter water, or do we try to fix the hot water, right? This is like a very classic discussion.
It's like they need like the little first aid cabinet with
Yeah.
what is it called? The defibrillator for the fish, where they teach them how to use it when they start to have heart attacks because the water's too hot.
Yeah.
And this is really getting to be Band-Aid to me.
In
That
fish
small,
size?
waterproof. I don't know.
They have
I
the
don't
little
know.
mini ones.
That's
Oh,
it.
yeah. But fish like guppies, I'm thinking.
I don't think. I don't think so.
guppy-sized
I don't think we have.
defibrillators?
Gotta use their
guppy-sized
fins to.
Yeah,
Yeah.
that's going to be
I
hard.
mean, this is like really far down in the this is like really into
Yep.
Band-Aid stuff. But
Yep.
it was interesting to me that there's like this is a whole field now.
Yeah.
This kind of,
And I guess you could conceptualize this happening across all of the different animal species that we want to preserve and protect. Like we would have to come up with a bespoke version for each of the different
like air conditioners for bees.
air conditioners for bees, right?
or like air filters for bees, like put them in like a little N95.
Yeah.
Yeah.
They're hard to get. Do they have ears?
Ears, I don't know. Maybe you need the ones that go around the back of your head.
You like put them over the wings.
Right. That's
The
what you would
straps
do.
over the wings. Yeah.
Oh my goodness.
Yeah.
We're devolving quickly here.
That's what we do.
What can I say? That's the end of our program. Thank you so much for joining us. We want to thank Nick Guler at BUSPH for sound and producing and editing. Thank you for joining us. We hope you enjoyed it, and we hope you download our next episode.